Good morning. I will be discussing about hairy cell leukemia. First, coming to the definition, what is hairy cell leukemia? So, let me tell it very simply. There are some abnormal B lymphocytes, okay, with fine hair-like cytoplasmic projections. Abnormal B lymphocytes तो है. Okay, there is abnormal B lymphocytes. Okay, so what? Abnormal B lymphocytes. So, what is for me? So then, what it's having fine hair-like projections, fine hair like cytoplasmic projections. Okay, there is abnormal B lymphocytes and there is hair like projection. So so what, uh, uh, this okay, and this presence of this hair like projections from the cytoplasm is rare. Okay, it is there and it is rare condition. Okay, we understood. And what is this? It's actually chronic B cell lymphoproliferative disorder. Oh, it is a chronic chronic B cell lymphoproliferative disorder characterized by this one abnormal B cell and presence of cytoplasmic hair-like projections. Oh, that's it. It's simple, right? Yeah. See, it is a chronic B cell lymphoproliferative disorder. Okay, it's a chronic and rare B cell lymphoproliferative disorder. Okay, and characterized by presence of abnormal B lymphocytes. Okay, abnormal B lymphocyte. We already know that abnormal B lymphocyte. What it have here, like projection from the cytoplasm. We already know it. So this is known as hairy cell leukemia. That's it. Okay, if you want me to frame an perfect definition to write in the hairy cell leukemia, what you can write is right. Hairy cell leukemia is a rare chronic B cell condition, a B cell lymphoproliferative disorder characterized by presence of abnormal B lymphocytes with fine hair-like cytoplasmic projections in the peripheral blood, bone marrow, and spleen. That's it. We understood the definition. We did not read the definition. We understood the definition. Okay, that's it. Coming to the etiopathogenesis, what we can see like uncommon mature B cell neoplasm. It is an uncommon mature B cell neoplasm. It's very rare, right? So it's uncommon and derived from mature B lymphocytes. Okay, we are getting this from mature B lymphocytes and associated with B rough and V600E mutations in most of the 95% of the cases we have seeing B rough and V600E. Okay, and mutations. Tumor cells infiltrate bone marrow, spleen, and liver. Okay, manual infiltration causes pancytopenia. Okay, it as tumor cells are growing more and more in the bone marrow, they will be occupying space. So marrow infiltration causes pancytopenia. So what are the clinical features? It is pancytopenia. So weakness and fatigue, recurrent infections due to neutropenia, weakness and fatigue due to anemia, fever also related to some neutropenia because recurrent infections are there and less immunity, and massive splenomegaly due to organ infiltration, hepatomegaly same, and okay, this one is same due to organ infiltration, and weight loss can be seen sometimes, and symptoms due to pancytopenia. This one only, all this. So we understood the clinical features. How I discussed all this because marrow infiltration causes pancytopenia, right? Most of the cells are decreased. So weakness and fatigue, anemia, recurrent neutropenia, fever, same neutropenia, massive spleen due to organ infiltration, hepatomegaly due to organ infiltration, weight loss, symptoms due to pancytopenia can be seen. That's one. Uh, these are from this one only we are taking, and laboratory diagnosis like peripheral blood smear we can see like pancytopenia. We know it's pancytopenia, we know before only. And pancytopenia, we can see hairy cells with delicate cytoplasmic projections. We can see that is this. See, here we are having this some cell like, and we have to some keep like hair like projections. That's it. It should not be round. It should be some like projections are there. And bone marrow increased hairy cells, and marrow fibrosis can be seen. Dry tap may occur. Okay, sometimes dry tap may also occur. And in the cytochemistry, what we can see is trap positive. What is that? Trap is tetrate resistant acid phosphatase. Okay, tetrate resistant acid phosphatase is positive. And okay, give me a minute, let me drink water. Right. Yeah. Okay, sorry for the delay. In the cytochemistry, we can see trap positive, that is tetrate resistant acid phosphatase positive, and immunophenotyping positive for CD19, CD20, CD11, C. Okay, these are all numbers. Let's try some codes. 19, 20, 11, 19. Sorry. Yeah, 19, 20, 11, 25. CD103. So I think 9 and 19, 20 we can remember. This one is somewhat out at 19, 20, 25, 11. And yeah, we can remember some like continuous numbers 19, 20 and upward 9, 11 and 25. Okay, then molecular study like BRAF and V600E mutation is positive in this hair cell leukemia, and treatment like we can do cladribine and interferon alpha. We can, okay, write this cladribine and interferon alpha, you write. These are important, these two are important. Splenectomy in selected cases by done. And prognosis like a slow progressive disease, it is slowly progressive, and good response to treatment can be seen, and long term survival rate is common. Okay, more common long term survival rate. And to explain, I think, what is this dry tap, I did not tell. Okay, what is this dry tap means? A dry tap means like a bone marrow aspiration. We will do bone marrow aspiration, right? So that time no marrow material, okay, or only thoda, only some marrow amount marrow can be aspirated despite needle placement in the bone marrow cavity. See, we are inserting a bone needle into bone marrow, but we are not getting anything, or very less we are getting. We are not getting, or less we are getting. Why? Because normally it is soft and can be sucked in the syringe, but here we in some diseases like packed with abnormal or replaced by fibrosis. So if it is like that, means it's not with normal cells and with abnormal cells, and there is fibros, some of the fibrosis. So there will be we can't aspirate, we can't take it. So sometimes dry tap can be seen here. So that is the dry tap. So this is about the hairy cell leukemia, and you can write this diagram, sorry, draw this diagram. And important like pancytopenia you have to write, and from that you can know all the symptoms. And next we are discussing about what are myelodysplastic syndromes. Okay, myelodysplastic syndromes are a heterogeneous group of clonal hematopoietic stem cell disorders characterized by ineffective hematopoiesis, peripheral blood cytopenias, and morphological dysplasia of one or more myeloid cells, in increased risk of transformation to AML. Okay, it's like Greek and Latin. Let's come on, everything we have to decode, so that we'll have a better understanding. So, myelodysplastic syndromes are heterogeneous group. Oh, okay, heterogeneous group of disorders, right? Of clonal hematopoietic stem cells. Okay. Are heterogeneous group of clonal hematopoietic stem cell disorders. Till now I understood. And which are leading to what? Ineffective hematopoiesis, peripheral blood cytopenias, and morphological dysplasia of one or more myeloid cells. Okay, I understood. And increased risk of transformation to AML can be seen. Now I understood. It is a group of heterogeneous clonal hematopoietic stem cell disorders characterized by ineffective hematopoiesis, peripheral blood cytopenias, and morphological dysplasia of one or more myeloid cells. I understood now. And etiology and prognosis. Etiology like primary myelodysplastic syndromes most common. Idiopathic usually occurs in elderly more than 60 years. This one. And secondary MDS like um, what secondary myelodysplastic syndromes. These are therapy related, occurs after chemotherapy, radiotherapy, benzene exposure, and environmental carcinogens. After the exposure, the secondary MDS can happen, and the primary MDS are mostly idiopathic, and we don't know the reason. Usually occurs in elderly people. And the pathogenesis, what we can do in pathogenesis is mutations occur in pluripotent hematopoietic stem cells. First one, pluripotent. In the pluripotent hematopoietic stem cells, the mutations happen. So, clonal proliferation of abnormal stem cells. There is, okay, pluripotent hematopoietic stem cells. There is mutation. Then clonal proliferation of abnormal stem cells. Okay, there is mutation in stem cell, and then proliferation. Chalo, next, defective maturation and differentiation. It is already the pluripotent is mutated, and proliferation of mutated stem cell only happened, and after cells production also, it is maturation is defective, and differentiation is also defective of marrow cells. Okay, then increased apoptosis of hematopoietic precursors. Okay, increased apoptosis of hematopoietic precursors, we understood till here. And hypercellular marrow develops. Okay, there is increased defective maturation and differentiation of marrow cells, and there is more and more proliferation, so that hypercellular marrow develops, and ineffective hematopoiesis causes cytopenia despite hypercellular marrow. See, there are more and more and more and more and more and cells, but still there is cytopenia. Why? Because ineffective hematopoiesis, because cytopenia despite hypercellular marrow, cytopenia will be there, so hematopoiesis will be ineffective, and some progress to AML, acute myeloid leukemia, some might progress. So what is the WHO classification is myelodysplastic syndromes, MDS, that is with low blasts, MDS, myelodysplastic syndromes with isolated deletion of 5q, and myelodysplastic syndrome with SF3B1 mutation, and hypoplastic MDS, MDS with increased blasts, childhood MDS. Okay, MDS with low blasts, MDS with increased blasts, MDS with isolated deletion of 5q, and hypoplastic MDS, and childhood MDS. Okay, you can write this. And sometimes MDS with SF3B1 mutation, you can give last priority. And clinical features like usually seen in elderly individuals. Okay, due to anemia, pallor, weakness will be there. Due to neutropenia, fever, recurrent infections will be there. Okay, due to thrombocytopenia, there will be take for bleeding tenderness will. Okay, this one due to cytopenia, right? So we can write what is happening in the loss of those cells, those particular cells, what will be happening, we have to write, that's it. And others like weight gain will be, not weight loss, weight gain, and malaise will be seen. And malaise lab, coming to the lab, peripheral blood smear shows macrocytic anemia. Okay, macrocytic anemia and anisopaglocytosis. And see, in most of the cases we see normocytic, normochromic, but here it is macrocytic. Okay, and WBC is like leukopenia, neutropenia, hypergranular neutrophils, hypogranular neutrophils, and pseudopagloroid cells can be seen. And so uh, platelets, thrombocytopenia can be seen, and giant cells, abnormal platelets can be seen. Okay, giant cell abnormal platelets. Okay, giant cell abnormal platelets and thrombocytopenia can be seen. And overall pancytopenia is common. Okay, overall pancytopenia is happening. So these are all the subtypes what is happening: leukopenia, neutropenia, hypergranular neutrophils, and thrombocytopenia, giant cell abnormal platelets, like that. And yeah, this is the thing. And coming to the bone marrow findings, you can see cellularity like usually hypercellular marrow, and occasionally hypocellular also, but most of the time it's hypercellular. And dysplastic changes like seen in erythroid series, megaloblastoid erythroid precursors, multinuclearity can be seen, and nuclear bonding can be seen. Okay, megaloblastoid erythroid precursors can be seen, multinuclearity can be seen, nuclear bonding can be seen. Then granulocyte series, hypogranulation and pseudopeculiar anomaly can be seen, that is in granulocytic series. Okay, now you might ask, what is this peculiar anomaly? Hello, hello. Okay, yeah. What is peculiar anomaly? So we are now discussing about granulocytic series, and this peculiar anomaly is an autosomal dominant inherited disorder in which neutrophils have hyposegmented nuclei. That's it. Usually bilobed or dumbbell shaped. So neutrophils show what? Neutrophils show what? Bilobed nucleus. Okay, spectacle or pin. Okay, leave that. Bilobed nucleus. So there will be this. Means these are a pseudopeculiar hyoid anomaly. That is what is an hyposegmented nuclei, usually bilobed. That's it. Okay, just remember hyposegmented nuclei with bilobed, which is usually bilobed. Of what? Of neutrophils. Then megakaryocytic series like micro megakaryocytes and hypolobulated cells. Then ring sideroblast may be present especially with SF3B1 mutation and cytogenetic abnormalities like deletion of 5q, monosomy 7, trisomy 8, deletion of 20q, and treatment supportive therapy should be done. Blood transfusion, platelet transfusion, antibiotic for three infections, yeah, and growth factors, GCSF, erythropoietin, and this is modifying therapy as azacitidine and decitabine can be given. But this treatment is like this drugs, again Greek and Latin, right? So you have to initially remember okay, this one also very somewhat numbers, right? So it will be hard. Ring sideroblast may be present, we have to see, we can know, but this one, so 5, 7, 8, 20. Okay, deletion of 5q, monosomy 7, trisomy 8, and deletion 20q. And treatment supportive therapy like blood transfusion, platelet transfusion. Okay, as we are having this low anemia, we are having thrombocytopenia, we are having, and neutropenia, we are having, we have to do blood transfusion. For platelets, we have to do platelet transfusion, and for treating infections as neutropenia is there, we have to do with antibiotics. Then growth factors also we can give like GCSF and erythropoietin, and this is modifying therapy like, okay, this one you can write azacitidine and decitabine. So you can write one of the drug. Okay, one of the drug is enough. And actually these headings are important: supportive therapy, growth factors, and this modifying therapy. These headings are important. And then curative therapy like hematopoietic stem cell transplantation you have to do, and prognosis depends on like degree of cytopenia. Okay, on degree of cytopenia it will develop, means how much extent it is there, and bone marrow blast percentage and cytogenetic abnormalities will describe the prognosis level. And most important, transformation into acute myeloid leukemia, it might sometimes myelodysplastic syndromes might transfer into acute myeloid leukemia also. Okay, this is all about myelodysplastic cells and syndrome and here is a leukemia. Thank you and subscribe. Bye. Have a great day.